beauty of learning psychiatry is that it is far away from being just like mathematics. And probably that could be the reason why AI is coming and invading into medical practice. But psychiatry most probably is likely to be the last specialty in medicine which is going to be invaded and taken over by AI. Thank you very much for your extremely patient listening.
Thank you so much, sir. It is always a joy listening to your classes. So I think we can take doubts now. I think one is already in the chat box. So kindly give an example of delusion of guilt.
Yeah. Delusion of guilt, it comes to situations where adolescents engage in sexual stimulating behavior, like masturbation, very common thing. A person becomes depressed. He doesn't talk to people. He doesn't give face to others. And he doesn't open up what he's actually going through. He attempts suicide. And after he's rescued and brought to a psychiatrist, after a lot of prompting, he opens up his mind and tells that I've sinned, I've masturbated, and God has understood that, and God is going to punish me. So there will be a lot of spiritual, religious connotations to that particular phenomenon, a lot of influence of what we call as Victorian morality. But still, we know from a scientific point of view that masturbation, as WHO calls it, it's the most healthy method of release of sexual tension. That is what is said. But still, the person feels that he has sinned to God and the God is going to punish him. This is an example of a delusion of guilt. Another question is there any prognostic significance for first rank symptoms? Of course, here again, for first rank symptoms per se, we can't say that there is a prognostic significance. But largely, majority of the first rank symptoms are positive symptoms. And we know from experience as well as evidence that anyone who has got more positive symptoms is likely to respond better to treatment. That is what we know. So, of course, if a person is coming to you with delusions or hallucinations which are very obvious, very visible, we are happy because it is very likely that our antipsychotic is going to work. And if a person is coming with negative symptoms, cognitive symptoms, we know that we have very limited things in our armamentarium. It may take a toll on our clinical practice itself, and it's going to be a long journey out. So, in that sense, of course, we can say that those symptoms can have a positive prognosis. Difference between delusional perception and delusional memory. Again, a wonderful question. So, delusional perception means there is a perception which happens at present, and I attach a delusional significance to it. The classical example I gave is that I am sitting now in a hotel and food has been served to me, and in the bowl which is there, there is a spoon with a crown. I see the spoon with a crown. It's an experience which I had in the present moment. But suddenly I get an idea that they have given me the spoon with a crown because I belong to the royal heritage, royal lineage. So I'm attributing a delusional significance to a perceptual experience which is in the present. Hope I'm clear. And what about delusional memory? Delusional memory is about something which happened in the past. I'm sitting now and telling you that when I was 5 years of age, my father's brother kidnapped me, took me to a particular room, tied me up, and beat me up like anything, and I was traumatized. Such an event has not happened. My parents don't remember, my relatives, none of them remembers, and none of my friends, nobody knows that I have been beaten up at that point of time. But still, I feel, I still, and I strongly hold on to that idea that I have been beaten up like that. So it's a thing of the past. That's it. Fregoli and Capgras once more with examples. Sure. Capgras delusion means a person who is very close to you, like, say, your son. You develop a delusion that that person is not your exact son. Your son has died years ago, and now an imposter. Imposter is the English term for avaran in Malayalam. No? An imposter with a physical resemblance to my son is taking my son's position, and he has got into my house with an intention of poisoning me, killing me, and taking away my property. So that is Capgras delusion. But Fregoli delusion means it is about one persecutor which is taking different forms and shapes. In Capgras, he is taking only one form, that of my son, or that of my wife, or that of my friend. He doesn't frequently change it. In Fregoli, a persecutor, a killer, a manipulator, he is taking different shapes and forms. One morning, he is appearing in the form of my father, and he is trying to poison me. I try to evade that situation. I go to my school or college, and suddenly I see the persecutor there standing in the form of my professor. So he's taking different forms and shapes with an intention of killing me. So I hope that is clear. So delusion of ill health versus hypochondriasis. Again, okay. Hypochondriasis is a situation in which you have a very strong feeling that you have got an illness. The example I gave was that I have got a throat cancer. I go to a doctor and specifically complain that I doubt that I have got this illness. I specifically ask for investigations to rule out that illness. And once that investigation is done and the results are normal, I become relieved. I am reassured by the reassurance given by the doctor temporarily for the time being. Maybe after a couple of days, again, I get the same thought. I go to another doctor. I do doctor shopping. I contribute a lot to the development of the corporate health sector of the world. But the thing is that once I am reassured by a particular clinician that all is well, I am relieved for the time being. But in delusion of ill health, I am not relieved by the reassurance of the doctor. I don't believe my doctor at all. I feel that the doctor is telling me lies because he is also part of the system which is trying to conspiring to harm me, the delusional system as we call it. I don't believe. Even after the investigation is done, I strongly believe that no, it is false. I have got an illness. It is that you are unable to diagnose it. That is it. How to differentiate between obsession of ill health and delusion of ill health? Again, interesting question. Obsession of ill health means it's a repeated thought. The example I gave was that rabies. Or maybe I'll give one more example. During the COVID season, a doctor came to me, not a modern medicine practitioner, an alternate medicine practitioner. When he was traveling in bus with a mask, an N95 mask on, somebody coughed in the back of the bus, and he was suddenly getting a thought that is it possible that this virus may travel all the way and get into my nose, and can I get COVID? So here he came to me and he asked me the question. I reassured him that it is very unlikely because the distance up to which a COVID virus can travel is that much. And if you wear a mask, it is very unlikely. I explained everything and he was relieved for the time being. But he returned the very next day to say that after hearing your explanation, which was very convincing, I was relieved. I had a good night's sleep, but next morning I got up and someone in the neighborhood was making loud noise. He was coughing at the top of his voice. Again, I had the same thought. So here again, remember that you are relieved by reassurance, at least temporarily. But if it is a delusion of ill health, you are not relieved. You 100% believe that you have got that illness, and you are not at all relieved by whatever explanation, whatever investigation results, whatever convincing explanation. Even if you are the best teacher in the world or the best communicator in the world, trying to give very clear-cut scientific evidence, the person does not listen to you. He feels that whatever you're telling is absolute lie. He has got that illness. So that's it. Multiple obsessions are also possible in a single patient. How common is this phenomenon in your experience? Definitely, multiple obsessions can occur in the same person, or obsessions can happen one after the other. That is also possible. So many people tell us this history that my son had this habit of excessive cleanliness when he was in 8th standard, but it got cured. And now he is not getting out of the room. He is not talking to anybody. He is not giving face to his relatives. They don't recognize that it is an obsession. Now we ask the boy, and he says that he is getting sexual obsessions of his own mother. He is unable to maintain eye contact with his mother. So it's possible that multiple obsessions can happen at the same time, or obsessions can follow one after the other. So maybe because the more visible or obvious obsessions like contamination obsession with washing compulsion, if they disappear, the parents, the relatives feel that the illness has been cured. But it has not been cured, it has been converted into a more difficult obsession which doesn't have very overt compulsion. So I have seen cases where obsessions and tics coexist, obsessions and ADHD coexist. All these are possible. Can obsession of ill health and delusion of ill health come under a spectrum? Definitely, it can come under a spectrum. Just like gender is a spectrum, sexual orientation is a spectrum, thought processes are also a spectrum. Of course, at one end is a feeling that you're supremely healthy. As we proceed, we can have an overvalued idea that there is something wrong, even especially if there is a family history of coronary artery disease, or somebody in your family has died at 40 years of age to myocardial infarction. You feel a little bit unsettled, an overvalued idea. Then later it can evolve into an obsession. And Frank Fish, in some of his earlier papers, had very famously mentioned that obsession, the wall of obsession can crumble into delusion. So now DSM-5 in 2013 agreed that there can be delusion with obsession with poor insight and obsession with delusional beliefs also. So that answers your question. It can be part of a spectrum. Is there any correlation between masturbation and Parkinsonism? Yeah, very interesting question. To the best of our knowledge, to the best of our knowledge, there is nothing like that to be mentioned. But there is more of relationship between masturbation and prostatic illnesses, we should say, because there's a lot of literature available about how if a person is celibate, his chances of developing prostatic inflammation and even prostatic cancers are high. So regular sexual activity, either a consensual sexual activity with a partner or even masturbation, can prevent prostatic inflammation to a certain extent. There is nothing at this point of time to suggest that masturbation precipitates Parkinsonism in any way. How to differentiate OCD with an obsession with poor insight and delusion? Very difficult thing to do, because here again, it is communication and the clarity of communication which matters. If a person with wonderful communication skills develops a psychopathology, he'll be able to clearly explain to you these things. But unfortunately, most of the patients we see may not be so communicative, and some of them might have had already certain cognitive disturbances. When the illness is very chronic, even if OCD is chronic, it can lead to cognitive disturbances, mood disorders also, psychosis also. Sometimes they may become suggestible, they may not give clear-cut answers. But how to differentiate is, it should be an intrusive thought, it should be an unpleasant thought, it should be a repetitive thought to call it an obsession. And poor insight means he knows that it is false, but still, what can I do? I know that this thought is false, but I am helpless in front of it. That is an OCD with poor insight. OCD with but delusion, or OCD with delusional belief, as you call it, it's a situation where a person resigns to this particular thought process, stops fighting with that thought process, does not try to push it out of his system, and lives in accordance with that thought process. One example is There was this particular lady who was the wife of a very big business person with business interests in 7 different countries in the world, who is confined to her own home for the last 14 years because she had developed an obsession 14 years ago after her second childbirth. And now it has gone to such an extent that whenever some visitor comes to the home, she wants to wash that particular area in which he sat with 5 different things: a soap, petrol, then some other detergents in a particular order. Now, what has happened is that when the girl child who is in the ninth standard goes to school and comes back, now she takes this girl of hers to the outhouse and cleans her up in a particular order in all these 5 different particles. Now the girl has revolted, and that has led to the consultation. So she is of the belief that this is the only way to get rid of that. It's like a delusion. Difference between OCD and OCPD. OCD, as we have already explained, it's a disorder which has got a particular origin. It started at around 17 years or 19 years to 21 years of age. OCPD, or obsessive compulsive personality disorder, or anancastic personality disorder, we can't pinpoint the age at which it began. The traits are visible right from late childhood, and throughout adolescence it is present. Perfectionism is the hallmark of OCPD. Perfectionism means you want to get things done in a particular order, and only if things are done in that particular order, it will be successful. No flexibility. Inflexible perfectionism, which is adversely affecting task completion. I can give you an example. In Kerala service rules so many years ago, there was this particular statement that a government official should have 5 different pens with 5 different colors. A particular matter, body of the matter should be written in green ink, the margin should be in black, the heading in certain areas should be red, and the sign should be in green, such things. So OCPD is a person who, if his green pen has run out of ink, will refuse to do anything at all. He'll not sign anything unless that green pen surfaces again. So that is OCPD. Again, is it necessary that a delusional misidentification always has a persecutory reference to it? Need not. Generally, mostly it may have a persecutory. It can have other connotations to it also. It can have erotomanic connotations to it. Sometimes, it is possible that erotomanic connotations or grandiose connotations may also be part of delusional misidentification. Difference between sexual obsession and paraphilia. Again, wonderful question. I'm extremely glad that such brilliant questions are surfacing as part of the discussion. So, in sexual obsession, let me make it very clear, it is a repetitive, intrusive, unpleasant thing. You are having an imagery of your own mother, your own sister, your own brother, or someone very close to you, or even God, and it is producing guilt. You are unable to enjoy it at all. You're feeling guilty, you're feeling disturbed, you're feeling distressed. But in paraphilia, even though on hearing about the paraphilia, the therapist may feel distressed, the client need not feel distressed. He enjoys it. He enjoys it. By definition, there are 8 different types of paraphilias, as we know, starting from exhibitionistic disorder to frotteuristic disorder to fetishistic disorder to transvestic disorder to pedophilic disorder. Different types are there. So even if a person is getting a sexual image of a child, an immature child, he's getting a sexual arousal out of it, he's getting pleasure out of it. So that is paraphilia. In sexual obsession, no pleasure, only guilt. Can the sexual obsession and paraphilia coexist? Again, wonderful question. There have been cases where such things have happened. Like, for example, it started in this way. This particular boy who was engaging in a lot of pornographic material watching right from his childhood itself. He claims that his father used to watch such material and he had a chance to witness his father watching such material. Then he explored and he developed pedophilic impulses to such a great extent. And he was taken to task once because at when he was in 12th standard, he tried to sexually assault a 6th standard boy in his own school, and it became a controversy, and some case was charged against him and he was sent for evaluation. So that boy was telling that he was having this images of his own mother, his own sister, but he used to feel intensely guilty about that. And he used to develop an erectile dysfunction also consequent to such visual images. Even though he used to enjoy the sexual images of underage children not related to him, he used to masturbate to those fantasies and he used to act upon those fantasies. Whenever he used to get a sexual imagery of his own mother and sister, he used to feel a transient erectile dysfunction. So that was one case where social obsession and paraphilias coexisted. Difference between made phenomenon, made act and volition, delusion of control, and somatic passivity. Again, this topic is outside the scope of today's discussion, but I'll try to make it as much clear as possible briefly. So, made act means, as Schneider has very clearly mentioned, someone is making me do it. So, this hand is moving because someone is making me do it. That is it. That is a made act. So, delusion of control means my mind is being controlled by somebody. The decisions which I take is being controlled by. And somatic passivity means there is an experience in my body which I am not initiating, I am not voluntarily initiating, it is being controlled by an external agency. Then how tricky is treating OCD with comorbid psychosis? Extremely tricky. There are certain situations where we get dichotomous illnesses which are opposite in nature. Like for example, seizure disorder with psychosis. OCD with psychosis is also another example because a large number of antipsychotics can worsen obsessions. And a few anti obsessional agents can worsen psychosis also. So it goes to be, it is one of the conditions which actually tests the skill of a clinician very much. So there can be situations where we need to opt for medications which doesn't produce obsessions. Antipsychotics, which are notorious to produce obsession, include number one, clozapine, number two is olanzapine. We need to avoid them. We need to go for conventional antipsychotics like trifluoperazine, for example, which may not worsen obsessions. And when we are opting for an anti-obsessional agent, also we need to go for something which has got an action on sigma receptor like fluoxamine, which is less likely to worsen psychosis. That happens to be the combination. So, somatic delusion and tactile hallucination. Again, wonderful question. So, this is again a very commonly asked question for the exam. So, somatic delusion means it is a thought that something is moving in the body, or somebody is touching you, somebody is fondling your genitals. It is the thought which is given maximum importance. While in tactile hallucination, it is the experience itself which is dominant.